Good afternoon. My name is George Phillip. Today I will be presenting a comprehensive review on cholangiocarcinoma for Masters of Public Health at the University of Toledo for the class Cancer Epidemiology with Professor Brian Fink. Let's start off with speaking about giving a quick intro to cholangiocarcinoma. So what is cholangiocarcinoma? Cholangiocarcinoma is a tumor that arises from epithelial cells that are present within the bile duct. Majority of cholangiocarcinomas are adenocarcinomas. What does that mean? The tumor actually arises from glandular cells. As cholangiocarcinoma is an extremely rare cancer, so why is it important when we study it in epidemiology? The reason being is because cholangiocarcinoma is a highly lethal disease. It's lethal because it presents at very locally advanced, it presents as a locally advanced presentation. Therefore, when looking at all patients in all different stages, the median survival is usually less than 24 months after diagnosis. The only potential curative treatment is surgical. Chemotherapy, radiation, and palliation have shown that they do not prolong survival. As stated before, this is a very rare disease. The annual incidence is approximately 1 to 2 cases per 100,000 in the Western world. However, the rates have been steadily increasing. So how do we classify cholangiocarcinoma? Initially, cholangiocarcinoma was defined as biliary tumors, meaning it included gallbladder cancer, tumors of the bile duct, and ampullary tumors. Tumors that were found within the bile duct, tumors that were found in bile ducts within the liver were actually considered primary liver cancer. The term cholangiocarcinoma has redefined biliary tumors. Cholangiocarcinoma has been further divided into its 3 locations: intrahepatic, within the liver; perihilar, just exiting the liver; and distal extrahepatic, where where the bile ducts are close to emptying through the ampulla vator and eventually the duodenum. The classification system has further included extrahepatic cholangiocarcinomas. Extrahepatic cholangiocarcinomas represent about 80–90% of all cholangiocarcinomas. We use what's called the Bismuth-Corlett classification, where it classifies the extrahepatic cholangiocarcinomas in 4 distinct categories. As you can see, type 1 involves the common hepatic ducts that are distal to the union of the right and left hepatic ducts. The type 2 involves right and left hepatic ducts right at the union. Type 3A involves the union of the right and left hepatic ducts, but extends up to the right hepatic duct. Type 3B is similar in that it involves the union of the right and left hepatic ducts and extends up to the left hepatic duct. Type 4, on the other hand, is multifocal and involves the biliary confluence and extends up both right and left hepatic ducts. These are, once defined as type 4, are usually not amendable to surgical intervention. So let's look at the etiology and risk factors. In most cases, etiology of cholangiocarcinoma is unknown. The risk factors, however, have been well studied. The most common risk factor in the United States is primary sclerosing cholangitis. Primary sclerosing cholangitis is an autoimmune disorder that causes inflammation of the bile ducts. It is commonly associated with ulcerative colitis, and with individuals with primary sclerosing cholangitis, the prevalence rate of them developing cholangiocarcinoma is approximately 5 to 15%. Anywhere else in the world, predominantly in Asia, the biggest risk factor for developing cholangiocarcinoma is infection, particularly C. sinensis, which is a parasitic infection that can be gained from eating raw fish or raw meat. This type of parasite causes inflammation and malignant changes to the bile duct cells. Other less common causes are colodocal cyst, Caroli's disease, cirrhosis, recurrent cholangitis, toxins such as Thorotrast, and now more commonly in the United States, hepatitis C and HIV. So let's look at the epidemiology. As stated before, this is a rare cancer. It represents less than 2% of all malignancies. It is the 9th most common gastroenterological malignancy and is the 2nd most common primary hepatic and biliary malignancy. The U.S. annual incidence is approximately 1 to 2 cases per 100,000, whereas in Southeast Asia, it's all the way up to 96 per 100,000. We assume this is because of the infection rate, particularly of C. sinensis in that region. When looking at the demographics, there is higher incidence among Hispanic descent and lowest incidence among African American patients. We also found that the incidence of cholangiocarcinoma increases significantly with age over 50, with the median age of development of diagnosis of cholangiocarcinoma at approximately 64 years old. Disease is slightly more common in men than women. The ratio of men is approximately 54%. And as stated before, there has been a steady increase in the incidence of cholangiocarcinoma over the past decades. So when looking at the clinical manifestation, one must also look at the difference between symptoms and signs. Symptoms are what the patient feels. Signs are what a clinician can often visualize. Most common symptoms in cholangiocarcinoma are painless jaundice. The patient will come in and say he has yellowish skin. Other common symptoms include pruritus, abdominal pain, weight loss, fever. Less common symptoms are clay-colored stool and dark urine. Signs, on the other hand, as also the most common symptom is jaundice at 90%. Other common signs are hepatomegaly, which is enlargement of the liver, red up quadrant mass, and Courvoisier sign, which is a very rare sign, but it is actually a pathognomonic sign for this kind of cancer. What it is basically a palpable gallbladder because of compression of the tumor on the cystic duct, the duct that leads to the gallbladder. So the diagnosis, how do we diagnose this? After we have clinical suspicion, we should first initially look at laboratory studies. Typically, laboratory studies will show signs of biliary obstruction, elevations of total bilirubin, direct bilirubin, alkaline phosphatase, and GGT are all suggestive. Tumor markers such as CA19-9, CEA, and CA125 may also be elevated in patients with cholangiocarcinoma. However, this is not specific. The definitive diagnosis must be preceded with radiologic imaging. The first test in any patient that has jaundice is to get an ultrasound. In this case, you can see by the arrows that you have dilated intrahepatic and posthepatic ducts. CT scan of the abdomen and pelvis may show you dilated bile ducts. It may also show you thickening and possibly a mass as well. MRCP and ERCP is the next most sensitive method of diagnosing this, in where you can typically see stricturing and dilation of the bile ducts, as well as sometimes a mass. Through ERCP, sometimes we can directly visualize the mass. Definitive diagnosis is actually usually accomplished with ERCP with brushing and biopsy. However, if tissue diagnosis cannot be confirmed that way, we need to perform it with ultrasound or CT-guided percutaneous drainage. In some cases, even that we are not able to get appropriate tissue diagnosis, and therefore it must be done by open surgical biopsy. Once the diagnosis is confirmed, then further imaging is needed for staging. This can be done by CT scan, chest X-ray, PET scan, laparoscopy, and MRCPs. So staging. There are three methods of staging: Bismuth, Blumgart, and the American Joint Committee on Cancer. This is a staging that is done by TNM staging. Tumor, the size of the tumor, how many nodes, and the possibility of distant metastasis. This is the most common method of staging, and the exact details are beyond this discussion. However, it is appropriate to know that stage 0, 1, and 2, as well as 3A, are considered amendable to surgical resection. So the most important staging issue is whether the tumor can actually be surgically removed, or whether it's too advanced. Indications where cholangiocarcinoma is not amendable to resection include atrophy of one lobe of the liver with encasement of the portal vein, atrophy of one lobe of the liver with secondary biliary radical involvement, bilateral portal vein branch encasement, bilateral hepatic artery encasement, distant lymph node metastasis, hilar cholangiocarcinoma type 4, intrahepatic and distant metastasis, primary sclerosing cholangitis, or if the patient has significant comorbid conditions. So let's talk about the treatment. As I stated numerous times before, the only curative method is surgery. Surgical treatment involves resection or liver transplantation. Certain details of the surgical management are beyond this discussion. However, it is important to know that patients may receive adjuvant chemotherapy and radiation after the operation. During a large multi-center prospective study, we have found that adjuvant chemotherapy is only effective for those individuals that have negative margins, meaning the entire tumor can be removed without any evidence of microscopic spread. Palliation. In cases where surgical resection is not an option, our only other option is palliation. What does palliation mean? It means to methods of treatment that we can relieve the symptomatology of cholangiocarcinoma. Our goals of palliation should include relief of jaundice, alleviation of pain, and relief of bowel obstruction. So, let's speak about the prognosis. The long-term survival is dependent highly on whether the tumor is able to be surgically resected, and if we're able to get negative margins, meaning able to remove the entire tumor without any residual microscopic disease. Early diagnosis and surgical intervention as well as adjuvant chemotherapy and radiation, has shown 5-year survival rates of 20 to 45% in most recent studies. However, if patients are not amendable to surgical resection, the median survival is approximately 5 to 8 months. In this concludes the presentation of cholangiocarcinoma. Thank you very much.